discussion is post-menopausal bleeding. So before actually starting with the topic, I would like to explain what is how to define menopause, right? So there are two types of menopause. First one is physiological, and the other one is surgical. Physiological we define if we are not if your patient is not having menopause for straight 12 months, then we call it as a physiological menopause. It can only be determined after 12 months of spontaneous amenorrhea. We should not hurry that if your patient comes to your OPD, she is not having like menses for let us say 5 to 6 months at a stretch. You should not label it as postmenopausal. You should wait ideally for 12 months, and then you can label it as menopause safely. So this is about physiological menopause. The surgical menopause is the removal of bilateral ovaries or bilateral oophorectomy, with or without hysterectomy, doesn't matter, doesn't change the cause. So the premature menopause may also be, apart from the surgery, it can also be because of the radiation or chemotherapy induced, or it can also occur after hysterectomy with ovarian conservation. If you fail to conserve the ovarian blood supply, both the ovaries will shrink over a period of time, landing the patient into surgical menopause. So now coming back to the topic, incidence is approximately 4 to 11% out of all the postmenopausal women population. The incidence of bleeding appears to correlate with time since menopause, with the likelihood of bleeding decreasing over time. More the female is spending her time into the postmenopausal age group, the bleeding incidence decreases. So what are different causes of postmenopausal bleeding? If we are talking about 50-year-old female or 60-year-old female, everybody must be thinking about the malignancies, right? But malignancies will always be the last cause here also. The most common cause of postmenopausal bleeding will be atrophic vaginitis or senile vaginitis that we all know of. Then the other causes are like traumatic. If your patient is having any grade 3, grade 4 prolapse, non-operable case, we advise them pessaries. Maybe they are causing some erosion and the bleeding might be because of that. You need to rule out the local causes as well. You need to check out whether your patient is on some kind of hormonal therapy. You need to go through the drug history of the patient, and then after ruling out all these, you should go for the benign and malignant causes. Benign causes such as cervical polyp or endometrial polyps are the commonest causes, right? The malignant causes you can find vaginal or cervical, endometrial, or any cancer of female genital or reproductive tract origin. It can also be post irradiation. It can also be a bleeding from adjacent organs. So once the menopause occurs, estrogen and progesterone are no longer produced by the ovaries in a required amount to cause the endometrial proliferation, nor are they produced in any appreciable amounts by the liver and fat, and hence endometrium regresses to a point where it should not bleed anymore. So if your patient is having menopause and still if she is having bleeding, that is a call or that is a sign to investigate her further. So when to go for an evaluation, right? So any menopausal women not taking HRT develops uterine bleeding after more than 1 year of amenorrhea, that calls for investigation. Any postmenopausal women on HRT for 6 months or more with persistent uterine bleeding, that calls for evaluation. Any previously amenorrheic women on HRT who begins bleeding without apparent cause is also an indication for further evaluation. So how to go ahead, or what should be your approach for the treatment? First and foremost, you should go ahead with the history. What all points you need to ask in the history? You should ask in detail when the bleeding started, what was the appearance of the bleeding when it started, whether it was associated with any vaginal discharge or any precipitating factor such as trauma, if she is using any pessary, if she is on any HRT or not, what was the nature of the bleeding, the pattern of the bleeding you would want to know about. Are there any associated symptoms such as pain, fever, or changes in bladder or bowel function, etc.? what is the medical history. If the patient is having any high risk familial history for HNPCC syndromes, etc., then you would want to go for the further evaluation. Also, if she is having any soy containing herbal or dietary supplements, that can also cause postmenopausal bleeding. So basically, you should all know about what she is eating, what she is, what are the medicines that she is having. All these are the things that you would want to ask in the history. After history comes the examination part. The general examination, you would want to know about the pallor, BMI of the patient, lymphadenopathy to rule out any malignancies, right? On abdominal examination, you would want to know about the palpable masses, if there is any ascites, to rule out the endometrial cancer or other ovarian cancers, etc. For local examination, before proceeding with the per speculum examination, you would want to know if there is any vulval ulcer or associated vulval bleeding because of any trauma. On speculum examination, you can see the atrophic changes of the vagina. The cervical erosions can also cause postmenopausal bleeding, vaginal lesions. You should also examine the uterus, bilateral adnexa to rule out any adnexal masses or uterine pathologies. After the examination, you would want to confirm your diagnosis. So you would advise few investigations. Commonly done investigations are ultrasonography. As we all know, for all kinds of pelvic pathologies, vaginal, transvaginal sonography is the investigation of choice. Apart from vaginal ultrasonography, saline sonography, endometrial biopsy, which can be done at a OPD setup, also called as office biopsy, followed by dilatation and curettage, hysteroscopic guided biopsy, which is an IPD procedure again. All these are the investigations that will help you to rule out the diagnosis. So how to proceed ahead with a patient of postmenopausal bleeding? So this entire slide will give you an idea to proceed how to proceed in a patient of postmenopausal bleeding. So first and foremost, send your patient to a good radiologist, get her endometrial thickness done. If it is more than 4 mm, ask for the high risk factors. If she is having high risk factors, then straight away go for B and C with histopathological correlation. If you are doubtful, if your patient is having persistent endometrial hyperplasia, hysteroscopy is the gold standard for treatment. If let us suppose she is not having any kind of high risk factors, then maybe office endometrial biopsy, OPD setup is enough. If your endometrial thickness is less than 4 mm and not associated with any kind of high risk factors, mere endometrial sampling at the OPD basis is enough. Saline infusion sonography, the introduction of intrauterine fluid during transvaginal ultrasound is one of the most significant advances in ultrasonography of the past decade. I have not myself personally seen that, but literature is talking very, very high about this particular sonography. So let's know about the endometrial biopsy. So endometrial biopsy is required if endometrial lining is thicker than 4 mm, if endometrium on sonography is showing diffuse or focal increased echogenicity or heterogeneity. If the endometrium is not adequately visualized on sonography, you would want to go for endometrial biopsy to rule out endometrial cancer if there is loss of endometrium and myometrial junction. If the woman, irrespective of your treatment, is having persistent bleeding, definitely she is a candidate to go for endometrial biopsy. So what are different ways by which you can get an access to the intrauterine cavity?